Thank you for the opportunity to present our work at this satellite. My name is John Stover from Avenir Health, and I'm presenting on behalf of myself and my co-author, Michelle Trench, also from Avenir Health. This is work done by Avenir Health in collaboration with the Coalition for Children Affected by AIDS. The purpose of this work is to understand current levels of expenditures for children and adolescents affected by AIDS. Children are defined in this work as ages 0 through 17. So we want to describe not only the amount of expenditures, but also the sources. And then we want to compare the actual expenditures with the needs in order to understand whatever gaps in funding might exist. In conducting this work, we wanted to look at expenditures for all low and middle income countries, but with a focus on 3 countries, Cameroon, Kenya, and Uganda. In this chart, you can see the trends over time in the number of children living with HIV in our 3 countries. Cameroon has about 38,000 children living with HIV today. Kenya and Uganda, about 100,000. Together, these 3 countries constitute just under 1/5 of all children living with HIV in the high-burden countries of sub-Saharan Africa. So now I want to tell you briefly about the methods used in this study. So first, we worked with local experts that served as consultants of this study in each of the 3 countries. And all 3 of these consultants are experienced in collecting and processing HIV expenditure information. The consultants met with members of the National AIDS Control Programs, ministries of health in country, as well as in-country donor teams from Global Fund, PEPFAR, and others. Once the data were collected and processed, they conducted validation workshops, which brought the main stakeholders together to review the data and give final approval. In looking at expenditures for all low and middle income countries, we relied on public data sources, primarily the Global AIDS Monitoring System, or GAM, which is a database where countries report on an annual basis their own information. We supplemented that with the detailed spending reports from PEPFAR, which are available on their Panorama Spotlight website, and also from the Global Fund online database. In looking at expenditures for children and adolescents, some categories of expenditures are obviously devoted 100% to children. For example, programs to prevent mother-to-child transmission of HIV, early infant diagnosis, pediatric treatment, support for orphans and vulnerable children, social protection programs, school fees. These are all 100% for children. But other categories of expenditures, such as programs for adolescent girls and young women, encompass broader age groups. So AGYW are 15 to 24. Some other expenditures are not disaggregated by age. So there we had to allocate a portion of those shared expenditures to the child population. We also add in an additional amount for support functions. So this is program management, research, health system strengthening, enabling environment, etc. The allocation rules depend on each category. So for example, if we look at expenditures for adolescent girls and young women, that's the category of ages 15 to 24. For this work, we wanted to pull out only the 15 to 17. So we took the percentage of all adolescent girls and young women who are 15 to 17 in each of these countries. It's about 20%, and used that to allocate that 20% of those expenditures to children and adolescents. Similarly, another calculation like that was done for each of the other categories. Okay, let's turn to the results then. First, looking at the 3 in-depth countries. This chart shows you the total expenditure in each of the 3 countries in 2023. So it's about 18 million for Cameroon, about 108 million for Kenya, and about 62 million for Uganda. The chart also shows that in addition to the total expenditure, it shows the components. So you can see for Kenya in the middle, for example, that large blue box at the bottom represents programs to prevent mother-to-child transmission, which is rather large there. Also, the red portion at the top is programs for adolescent girls and young women. In Uganda, by contrast, the expenditures for PMTCT programs are smaller, but there's also a larger component in that dark gray area for VMMC programs. Cameroon spends less than the other 2, but also it doesn't have some of the components such as VMMC programs that are required in the other countries. When we look at where the funding comes from, this chart shows us how much of the funding in each country comes from the government, which is the lowest blue bar, by PEPFAR, which is the orange component, Global Fund in gray, and then other donors and private sector. But we can see that in Kenya, somewhat over 20% of all funding comes from the government, while that component is much smaller in the other countries. Uganda relies primarily on PEPFAR, Cameroon on a mixture of PEPFAR and Global Fund to support its programs. Now, we also wanted to look at the gaps in spending. So first turning to programs to prevent mother-to-child transmission. In both Kenya and Uganda, coverage is nearly at the global goals of 95%. So there's really no gap in spending for PMTCT programs in those countries. In Cameroon, however, there's a gap of about a third. Additional funding would be needed in order to bring Cameroon up to the global goal of 95% coverage. When we look at the gap for pediatric treatment, however, we can see the story is much different. Here, none of the three countries are at the global goals of 90% coverage, so that we have a gap of about a quarter in Kenya and Uganda and more than half in Cameroon. So this is purely based on the coverage in those countries, so it's quite easy to see that we would need this much additional expenditures to reach those goals. However, it doesn't mean that it's just money that's holding us back. It doesn't mean that there's not enough funds and children will be turned away. In fact, for pediatric treatment, the largest problem seems to be identifying all HIV positive children. In many countries, we do a really good job about testing mothers and children at birth and delivery, but once a child reaches the age of 5, they no longer have regular contact with the health system for vaccination visits, mother well baby visits, etc. So then it becomes harder to test those children because you don't have regular contact with them. So we believe that a majority of these children who are not identified are older. They're age 8, 10, 12, 14 or so. And that's where our efforts need to focus, is identifying these older children so that they can be brought into treatment programs. So it's not just a matter of money, but it's also a matter of focus and how do we find these children. The next chart shows you the expenditure per child living with HIV. And you can see it ranges from about $500 in Cameroon to over $1,100 in Kenya. This reflects both the intensity of the effort, the coverage. Coverage is higher in Kenya and Uganda than Cameroon, but also the mix of the programs that are necessary. So, for example, Uganda spends quite a bit on the VMMC program, which is not required in Cameroon. So this gives us a range across the countries that's affected both by their coverage, how they deliver the programs, and the components that are required. Now turning to the expenditures for all low and middle income countries. This chart shows us the distribution of spending in the latest year available. So it's about $1.85 billion in total. And you can see that the three largest components are for programs to prevent mother-to-child transmission, pediatric treatment, and social protection. The children and adolescents slice here represents expenditures on children and adolescents that are not identified by a specific intervention. And then you see some for support. So, but the big three, PMTCT, ART, and social protection, account for almost 3/4 of total expenditure. When we look at the sources of funding, we can see that about a third of all the funding comes from domestic governments. Just under half comes from PEPFAR, from the PEPFAR program alone. And then Global Fund contributes about 15% or so to that. Now, when we look at gaps for all low and middle income countries, we can apply the same approach here. So the first two bars show you the gaps for PMTCT programs and treatment programs. So here, the orange part of the bar shows you the additional expenditures that would be required to bring all low and middle income countries up to the global goals for 95% coverage of PMTCT and 90% coverage of ART for children. For the other categories, that's not so simple because we don't have good coverage measures. So here what we've done is we've compared the current expenditure with the estimated need from the UNAIDS Global AIDS Strategy. Now, this was done 4 years ago now, so it's a little bit old. And the categories used in that strategy do not always match up exactly with the categories we see for expenditures. But it gives us some idea of where the gaps are. We have to interpret these numbers with caution, but I think it does indicate to us that there are big gaps in terms of economic support. We're doing a lot less than we really would like to be doing in this area, and particularly also around key populations where spending is a lot less than we'd like it to be. Finally, I want to show you the information about PEPFAR spending. So this is a special analysis that was conducted for us by PEPFAR. They analyzed their budgets for the country operational plan year 2022. In this case, PEPFAR budgets and expenditures are closely aligned, so you can consider that these are very close to expenditures. PEPFAR expends about $1.2 billion on programs for children and adolescents here, and you can see the distribution. About a quarter is for care and treatment, and then larger components for prevention, for support for OBCs, and PMTCT programs. Altogether, when we look at PEPFAR spending compared to everything, it suggests that PEPFAR is supporting at least 45% of all spending for children and adolescents. So it's a major component of the support that we're providing. So in conclusion, we can recognize that current spending for children and adolescents is about $1.8 to $1.9 billion. Just under $1 billion of that is spent in the 21 highest burden countries. For PMTCT programs, the spending is nearly adequate for all countries to achieve the global goals. Most countries are very close to these goals. For treatment programs, however, we're only at about 65% coverage. So there's still a large treatment gap that remains. Some of that has to do with expenditures, but perhaps our most pressing need is to be able to identify all HIV positive children, particularly those who are older, in order to bring them into care and get them on treatment. About 3/4 of all expenditures for children and adolescents come from three categories: programs to prevent mother-to-child transmission, pediatric treatment, and social protection programs. So those are the big three. And finally, we need to recognize and applaud the work of PEPFAR, which contributes just under half of all spending for programs to support children and adolescents. Thank you for your attention.